It's great to be with you all again. And I have to say that this is one of the organizations that I really look forward to being a part of because of the work that you do. My name is Robert Winn. I am the Cancer Center Director, proud Cancer Center Director of the Virginia Commonwealth University Massey Cancer Center. It's located in Richmond. It has been a NCI designated program since 1974, and I'm the fourth Cancer Center Director. The interesting thing about what I'd like to talk about today, and I think what, again, this organization is all about, but my Cancer Center over the last 3 years since I've taken over since 2020 has been about, is making communities visible. Now, I'll be the first to tell you that I love science. My work is in RNA binding protein. I have been at the bench since the early part of my career. But what has happened to me over time has been more of an evolution than a revolution of understanding that while I was creating new knowledge, the fact of the matter is that much of that new knowledge was not getting out or impacting communities. What I love about what you do, and what most of what I'll have to talk about in the rest of the conversation that I'm having with you now, is to point out really two things that are my guiding post. The first is actually a quote from Mark Twain that says, "It ain't what you don't know that gets you into trouble. It's what you know for sure that just ain't so." Now, the interesting part about that is that I think in basic sciences and in our translational sciences and medicine, there's been at times the definitely needed arrogance to come up with miracle drugs, but also the hubris of thinking that just because you come up with the drug, that it's actually the solution to all the world's problems. It also turns out that, and we'll come back to this theme, that we have known certain things for sure, but then when data comes out later, we've had to change our thinking. I've been, as a Cancer Center Director, challenging this, what we know for sure, and the principle of what we know for sure is just the creation of new drugs is actually going to be the be-all and the end-all of eradicating cancer. It's just not so. In fact, at the launch of 1971 and the war against cancer, Nixon and others proudly proclaimed that we would eradicate cancer by 1981 because we had now unlocked the secrets of the nature of the human cells, and it would only really take us 10 years to figure everything out and eradicate cancer worldwide by 1981. It turns out that we've certainly made a lot of progress since 1971, but the eradication of cancer has just not been so. I'm going to first argue that this first principle of knowing what you know but not being arrogant, and that having a little bit of humility of understanding that we can't know it all, is important in the context of the work you do. It turns out that the discovery of molecules that become medicine may be necessary in the fight against cancer, but are certainly not sufficient in reducing health disparities. The second, and I really, really have come to appreciate this saying by Albert Einstein, is that not everything that can be counted counts. Not everything that can be counted counts. And there are things inherent with that can't be counted, that may matter. What I mean by that is that as we are starting to look at the impact of cancer centers, the impact of what we do as a collective group, we tend to sort of talk of these issues about things that can't be measured, aren't done. But here's something that's actually interesting to me. There are things that can't be measured, at the moment anyways. Community connectiveness. We're not looking at the overall community intelligence. In fact, one of the things that actually happened to me once was I brought a group of my best and brightest scientists into the community, trying to bridge the gap. Interestingly enough, one of my scientists at the time made a statement, well-meaning statement, by the way. Imagine being on the south side of Chicago, roughly about 150 different people from the communities, by the way, from the 14th Ward at that point. And having one of my speakers says, well, we know that you are all scientifically illiterate. It's like a movie. In fact, I wish it was almost in slow motion as the words came out, scientifically illiterate, and you could see me almost saying no in slow motion. But it got said by a scientist who wasn't an idiot, and by a scientist who wasn't trying to be a jerk. The scientist is well-meaning, because honestly, that's information that we all take all the time about being scientifically illiterate. Our communities are scientifically illiterate. That's what we say, or health illiterate. An 80-some-year-old woman winds up getting out of her chair and literally shuffling over to the mic, at best I can remember. And she turned around and asked one of the young guys who helped her get to the mic, what did he say, scientist? And she said to me, and she said to all of us, well, we might be scientifically illiterate, but you are illiterate too. Now that statement, that is a group of amazing scientists and clinician and clinical trialists that we were standing before a community and being told by someone who lived in the community that they admitted that there were some health literacy issues or some scientific literacy issues, but that we were illiterate too. Stuck with me. It stuck with me in a way that one of the reasons why I was driven to make this presentation today without slides is that occasionally, sometimes we use the slides to skirt around really the big conversations that we should be having about the humility that's needed to do this job. As a cancer center director, I had a couple challenges. One, why were we so fixated on a bench to bedside model, when many of the people who we needed to treat couldn't even get to our bedside? Now, I'm not knocking the fact that modern day medicine has relied on the amazing things that have happened since 1950 with the discovery of DNA, about being able to understand the nature of the human cells. I would never argue that the 120 years it's now taken to come up with our miracle drugs of immunotherapy or the molecular targeted therapy aren't really miracles. I would submit that to you. But I would also submit to you that we have focused so much on the discovery side that we have forgotten about the other mission to improve health outcomes and have impact. This is where organizations like Prevent Cancer and others have emboldened me over the years as a cancer center director to be unapologetic about being the first cancer center in the country that was explicit that we were certainly not against a bench to bedside model, but that we would create a community to bench model, or something that we've called the people to pipette approach. What do I mean by that? What I mean by that is that we're figuring out that when even there are communities, what I call the missing millions, that there are data deserts among those missing millions of people that we ultimately count. What we figured out here is that by literally not hashtag putting the community first, but by putting the community first, we're now challenged to create and expand our understanding of our communities, where they live and how they live, because it turns out that while biology is certainly important, and certainly DNA drives disease, we also understand that the ZNA, and for those of you who don't understand that, and yes, I just said ZNA, otherwise, in other words, your zip code neighborhood of association, also plays a significant role. It turns out that the new science and why prevention matters is because we understand that post-COVID, that it wasn't so much the downstream fundamental signaling pathways that we were looking at that actually drove the divide amongst groups. It was the upstream social drivers of health. Many, by the way, that can be addressed. Now, someone may just stop and say, time out, Dr. Winn, why did you just say social drivers as opposed to social determinants? Well, let me tell you that when I looked it up in a dictionary, it appeared that when we talk about determinants, there's almost a sense of fatalism with that fate has been cast. The things we put in place are not all based on fate. They're based on structures that were created by us. Now, what do I mean? Let me give you an example. When I grew up and became a medical student and a resident and junior faculty, I was under the belief that African-Americans just certainly did, and we're just picking on African-Americans at the moment, we can do other groups as well, but let's just stick with African-Americans for the moment. I grew up believing that African-Americans with multiple myeloma just did poorly because they were Black. I was also under the impression that just because I was Black and other African-Americans in the country were destined to actually have a poorer outcome from prostate cancer, not because of anything other than the fact that I was Black. It was the information of the age of what we knew for sure. Well, turns out that it may not just be so. Listen, we have new data now that actually says that when you give the same access to care, when you give it in a timely manner by the same docs and is delivered the same way, you not only reduce the difference between Black-white deaths from prostate cancer and multiple myeloma, but in some cases, some of those groups, African-American groups, even do even better. How do we get here? And why is a group like Prevent Cancer even more important now than ever before? Well, it turns out that we're finally, for the first time, recognizing that the same groups that get the worst cancer also have the worst access to food, the worst access to transportation, increased stress levels. And yes, even living in context of heat islands, whether you're living in Baltimore, Philadelphia, or the South Side Chi-Town, meaning that the surface differences between the well-to-do community and the poor communities is so different that we know it contributes to disease. We also know that the practices of the past of separating communities, like redlining, have also allowed many of those communities, right, with increased prostate cancer and all these things, to live among highways with exposure to diesel fumes. And by the way, those same non-desirable areas that were created in the 1950s and 1960s with the urban renewal projects were the same neighborhoods that many of the companies that were undesired to be in high-end neighborhoods wound up being in poorer neighborhoods. What does that mean? That means things like particulate matter 2.5 that's associated with cancer have been disproportionately affecting places of poor and color areas than they have with other people. We should stop talking about the fact that African Americans just are more, predisposed to actually dying from prostate cancer just because they're Black, and have much more of an honest conversation that it's not maybe so much the DNA as it is the ZNA driving that you're a zip code and neighborhood of association that allows you to actually be much more exposed to things that could be cancer causing may play a role in the poor outcome. That the fact that you can't see or can't seek healthcare in a timely manner, or that even when you do, the health systems that you may be a part of may not even have the staffing or the expertise or whatever to give you that high level care that some of the other people have. We need to stop playing that the miracles of drugs, which are absolutely necessary, are sufficient to eradicate disparities. By the way, I use the word disparities deliberately because when we talk about health equity, and I know we want to talk about health equity, but health equity is much more of a principle that, that all people are equal and we eradicate disease between groups. But hear me for a second. The example I gave you with multiple myeloma and the example I gave you with prostate cancer says that independent of your mutation, if you just got the standard of care, your outcomes and the difference between Black-white outcomes and that Blacks having poor outcomes would be eradicated. It has nothing to do with your biology. It has to do with the structure in the system. The truth of the matter is, as we think about cancer centers in the 21st century, and as we think about cancer in the 21st century, We have to be able to bridge the critical disconnect between our fascination with the discovery sciences and connect it much more to the delivery sciences. Part of that delivery is obviously going to be about screening and effective screening, but part of that is going to be focused on prevention strategies. We understand that diabetes and obesity and that living in areas where you don't get exercise and there's consumption of alcohol, and when there is a difference of surface exposures, of temperature, all those things contribute to increased cancer risks. The issue is just acknowledging it is not enough. The call to action is that not only, and what I love about your group is that the call to action by your group to other cancer centers and anyone that will listen is to start paying attention that prevention matters. I think, and you may call me an optimist, that we're finally at a crossroads of understanding that we've spent 50 plus years developing new therapies. But what we haven't spent equal amounts of time on is how do we get those therapies distributed fairly. With every new sort of screening test or every new drug or every new test, as a society, we have inadvertently increased disparities. If you don't believe me, just go back to the data. Turns out that the Black-white gap in breast cancer explosion happened with the introduction of the mammography. That the difference between Black-white outcomes and colorectal cancers started with actually the colorectal screening. As we talk about our new testing, as we talk about our new abilities to screen quicker, as we talk about our new machines and all this most wonderful thing, I'm reminded that of an incident that when I was on the south side of Chicago, we were talking about the importance of artificial intelligence and being able to detect new breast cancers. And yet I was standing in the midst, and Dr. Tosis actually has a picture of this I wish I could show you, in which we were in a community hospital where there was a live manhole. And the people weren't reading digital or AI radiographs. They were using analog. The future is here, folks. It's just unevenly distributed. It turns out that we can level the playing field by focusing in on more effective screening, but we can really level the playing field, particularly with some of our rural communities and our urban underserved communities, by being much more aggressive with prevention strategies. My goal is just to remind you of the following. Number one, I think Theodore Roosevelt said it, but I thought it was my grandmother. People don't know how much you care. People don't care how much you know until they know that you care. As an organization, as a cancer center director, I have to say we can certainly do a better job illustrating better and communicating much better that we care. I'll leave you with this. In 1969, on the eve of the Apollo 11 launch, we were going to put the first person on the moon. It turns out that there was a major disruption, a major sort of protest, if you will, by Dr. Reverend Abernathy, who was friends with Martin Luther King, Reverend Shuttlesworth, and et cetera. They made such a ruckus that the deputy director of NASA had to come out. His name was Dr. Payne, and he finally came out and says, "Could you please stop? This is an embarrassment. The communists will use this against us." And then Dr. Reverend Abernathy stopped him and says, no. I celebrate in our prowess of bringing science and our dominance of the world of science. But can you tell me, why can you put a man on the moon, but just 3 miles away, you can't address the poverty that's there? And without missing a beat, Dr. Thomas Paine, who's the then deputy director of NASA, looked at the ground and looked at Reverend Abernathy and said, you know what, because it's easier to put a man on the moon than it is to address those issues. In 2023, I ask, does it remain easier to put our neighbors into space than it is to address these issues? I say no. I want to thank you for your time. I want to thank you for listening to me. I want to thank you for the opportunity to actually just talk without slides about the call to action and about the importance of organizations like Prevent Cancer. I'm in that fight with you. And in fact, I may be the only cancer center that believes that we lead with prevention and then we treat with medicines when necessary. I may be the lone voice, but when I'm in company like yours, I'll take it. I think we're on the right track. Thank you for what you do, and thank you for listening to me today.